So without much ado, we will start the talk. I'll be speaking first on amblyopia, mimickers, and masquerades. So what's a mimicker and what's a masquerader? So I think I will clarify this first before moving on to the topic first. So an ophthalmic mimicker is usually a lesser known disease which closely resembles a familiar ophthalmic disease and confuses the clinician. For example, cataract, which can masquerade as a squint, or retinal pathology, which can masquerade as a squint. Whereas a masquerader is usually a dangerous disease which can disguise as an innocuous condition. Just like that, for example, retinoblastoma masquerading as a squint. So that is, I'd like to say, this is what is a mimicker and a masquerader. So we're going to look at some amblyopia mimickers. So let's look at this case scenario of a 19-year-old healthy girl. She was accidentally noticed to have blurry vision during a driving license test 6 months back. She had consulted elsewhere and was extensively evaluated and was told that she was probably having a refractive error with amblyopia and even the possibility of malingering because her visual acuity was 6/24 N6, not improving further with glasses or pinhole. So when we saw her, she had a normal ocular alignment. She had good binocular vision as Würzburg daughters showed fusion, but stereopsis was just about borderline, 200 arc seconds. Pupils were good, there was no RAPD, color vision was full in both eyes. And this was a fundus. It essentially looked normal to us initially. And we actually had a cursive glance to the OCT. It didn't really ring a bell then. We did a visual fields. She had bilateral central scotoma. It was repeated, again bilateral central scotoma, a pattern VP, full field DRG, EOG, all were within normal limits. So we thought we'll have a closer look at her OCT and also at her multicolor picture. You could see there were this small yellowish white retinal flecks, a suspicion, not even flecks, some deposits at the macula. And the fundus autofluorescence was very dramatic. She had this, hyper autofluorescence on FAF. And that's when we thought, let's look at the macula closely. And we found that she had some amount of foveal atrophy with ISOS junction disruption, which was and this raised the strong suspicion of, are we really dealing with an amblyopia or is there a structural problem? And then we thought this could be an early macular dystrophy. So that's when we did an MFERG, and you can see here there is reduced foveal peak in the right eye and the foveal peak in the left eye is absent. So then we thought of doing a genetic analysis, and to our surprise we got an ABCA4 mutation, came out as positive, and this ABCA4 is, it is indicated in Stargardt's disease and ABCA4 retinopathy. So probably we were dealing with a case of ABCA4 retinopathy or an early Stargardt's. So there goes the importance of doing a detailed evaluation. So next was this 15-year-old 10th standard student, again was referred for squint surgery. He was diagnosed to have strabismic amblyopia. He had a right exotropia, resistant to patching and glasses. When I saw him first, I thought he was relatively short-statured for his age. He was cushion-eyed, baby-faced. For a 15-year-old, he really looked underage. So then I looked into his fundus. This was his fundus, bilateral optic disc pallor. We did an OCT. There was definitely retinal nerve fiber layer thinning in both eyes, right more than left. And something was not right. I did the fields. This is the field I got, bitemporal hemianopia. So definitely he must be having something, and we imaged him, and this is what we got. He had a large pituitary macroadenoma which was compressing his chiasm as well as the right optic nerve, and that was the reason for his right, both bilateral optic atrophy, right more than left, and him going into an exotropia. So he was referred to the neurosurgeon. He underwent a surgical excision, but I think he continues to have poor vision in the right eye. The third case was again referred as anisometropic amblyopia, a 7-year-old healthy boy, best corrected visual acuity not improving beyond 612, 618, no history of consanguinity, no similar illness in the family, color vision was poor. This is his fundus. Optos picture initially looked good. I couldn't find any abnormality. But there was something in the history. His father was saying he's stumbling at objects at night. That was the catchy thing. So we did an ERG, and you can see here the photopic responses are all good. But look at the scotopic or the dark adapted responses. Even you have a negative B wave here. So can you see this is the A wave, and where you are supposed to have the B wave, it is a negative B wave. So that brought us to the suspicion, are we dealing with the case of night blindness? And that's when we did the genetic analysis, and he came out positive for the TRPM, that is the transretinal protein mutation positive. So that is again very points to the diagnosis of congenital stationary night blindness. This is another case of an 8-year-old boy, again had poor vision, right eye fairly okay, 612 N6, left eye CF2 meters, N36, compound hypermetropic astigmatism, diagnosed as anisometropic amblyopia. Right eye was okay, left eye had some patches of subretinal fibrosis, and you can see these pigmentary changes. He definitely had a pathology in the left eye, and on a closer look you could see this schitic areas which was beautifully delineated in the OCT, and this turned out to be a case of juvenile X-linked retinoschisis with a bicycle spoke wheel maculopathy. Another case referred to us as refractory ametropic amblyopia, 11-year-old boy, difficulty in vision, squeezing eyes. And again, he had compound myopic astigmatism, no history of consanguinity. Fundus essentially looked normal to us. But the red flags in the history were poor vision, poor color vision. He was squeezing his eyes even in the room light in my OPD. Fine nystagmus, and sister having similar complaints. Again, an ERG was done, and you can see here the scotopic responses are very good. But look at the photopic responses. The light responses are totally absent. So this, again, we did a genetic analysis, and the CNGA3 gene came out as positive. So this was a case of achromatopsia. Again, this girl was referred as amblyopia, poor vision, myopia. Fundus looked normal, except that I couldn't get the foveal reflex. So she had poor vision, nystagmus, photophobia, no foveal contour on OCT. So this was highly suspicious of foveal hyperplasia, and we are evaluating her. So there are a lot of literature search, evidence for mimickers and masquerades of amblyopia. We had a similar case of a child referred for squint surgery, eventually turned out to have a brain CNS glioma. It was masquerading as an esotropia. So what I want to say is that to rule out before you think of amblyopia, get a detailed history, establish an amblyogenic risk factor before you label as amblyopia, rule out an organic cause, and do ancillary investigations, image wherever necessary. Electrophysiology does help, and genetic test clinches it. All that does not see well is not always amblyopia. Thank you. Now I invite Dr. Neetu Mohan. She's the senior consultant and head of the Department of Glaucoma in Aravind Eye Care System, Chennai, to talk on potential mimickers of glaucoma.
Thank you, Nina, for the opportunity to be here in KSOS and the chance to meet up with old friends and most respected teachers here. That was a fantastic collection of cases that we saw there, beautifully documented. So I'll be talking about potential mimickers of glaucoma. So we will discuss this under two headings. One is the open-angle glaucomas, where, as you know, a diagnosis of glaucoma is made by the characteristic appearance of the disc and the field changes that you are going to see. So a number of conditions which can cause similar changes to the disc or RNFL or the fields can be confused with glaucoma. With open-angle glaucomas, what you are most concerned about is about missing a diagnosis which is a neuro-ophthalmological cause for cupping. So we'll discuss this, and then we'll also cover congenital conditions, retinal diseases, some others like high myopes, disc size asymmetry, and toxic neuropathies. Angle closure glaucomas, mimics of angle closure glaucoma, though not so common, these patients are acutely symptomatic and you are pressed to make a diagnosis immediately and to go on with the treatment. So we'll discuss a few of these too. So coming to mimickers of open angle glaucoma, neuro-ophthalmological disorders, this is a 82-year-old gentleman on follow-up with us for past 6 to 7 years. He's a known case of primary open angle glaucoma. Over a period of 7 years, we have stepped up the anti-glaucoma medications. He's on 3 medications currently. And these are his fields over the years. You can see his fields were relatively stable over the years. And here on the 5th field, we see what was at that point of time diagnosed as progression in the field defects, and anti-glaucoma medications were stepped up. But then 3 months later, when we repeated a field, this seemed to look more like a vertical hemianopia now. So this made the consultant ask for further investigations, and the MRI at that point of time showed an old right PCA tertiary infarct, which was probably missed earlier. So what are the points that tells you that this is not glaucoma? You have to pursue this further and look for another cause. Most importantly would be the history. When there is a sudden onset visual loss or when there are other symptomatology which suggests a neurologic pathology, you have to pursue it further. A young patient with normal intraocular pressures is not glaucoma unless all other diagnoses are ruled out. In a young patient diagnosed as NTG, a diurnal variation neuroimaging is a must. And even if a diagnosis of glaucoma is made, this patient should undergo sleep study, ocular blood flow analysis, and carotid Doppler to rule out the risk factors for NTG in young patients. A drop in visual acuity and color vision points to a diagnosis which is away from glaucoma. Please pick up the pen torch, look at the pupil. A relative efferent pupillary defect that does not correspond to the amount of cupping that is expected in glaucoma points to a diagnosis which is something else. The classical teaching of pallor more than cupping still holds good, but having said that, any IOP spike, even in an angle closure glaucoma or a pseudoexfoliation glaucoma, when you have an acute rise in IOP, this itself can cause a disc pallor. So be guarded about just going by disc pallor. Perimetry, as mentioned, vertical hemianopia, central and centrocecal scotomas are a diagnosis away from glaucoma. And in OCT, you would see more of temporal RNFL thinning and diffuse RNFL thinning in neurological disorders, as opposed to glaucoma, where you would see superior and inferior RNFL loss. So coming to the congenital conditions, optic disc colobomas, optic disc pits, and tilted discs are very often confused with glaucoma, and since many of these conditions coexist with high myopia, it is very difficult to at that point of time make a diagnosis of glaucoma. It is good to have baseline perimetry and fundus photographs in these patients. OCT RNFL whenever it is possible to get a good image, and follow these patients over time to just prove that these changes are not progressing over time, or in many cases the conditions may just coexist. Glaucoma and an optic disc pit can coexist. So this is one patient on follow-up with us for a long time. She had superior segmental optic nerve hypoplasia or the topless disc syndrome, characteristic superior disc pallor, superior peripapillary scleral halo. You can see these diffuse RNFL defects superiorly, which was this corresponding changes in OCT RNFL, and we have a perfect field which corresponds to the OCT with an inferior altitudinal field defect. And we were following her up over a period of time, and then due to COVID, she was lost to follow-up for 2 years. And then when she came back, we were surprised to see a drastic progression in fields over a period of 2 years. And then apparently SSOH is also a risk factor for normal tension glaucoma in young patients. The impaired retinal development during fetal period might cause vulnerabilities to the optic disc and retina, which predisposes these patients to NTG. So currently she has been started on an anti-glaucoma medication, even though her diurnal variation in IOP were also normal. Morning glory anomaly is not very often missed since this characteristic disc appearance is striking, but these patients need neuroimaging to rule out the systemic associations. Coming to retinal diseases, it is important to know that rim sloping or pallor or even a retinal nerve fiber layer defect, as you can see here, a characteristic RNFL defect is seen inferiorly, but you can also see sheathing of the vessels there. This is an old retinal vein occlusion, a branch retinal vein occlusion which has been lasered. So any pathology which causes a ganglion cell loss will also cause an RNFL defect or even rim sloping and pallor. So in the presence of a coexisting pathology, it is good to have baseline investigations and follow these patients up over a period of time, especially if the intraocular pressure is normal, rather than brand them as glaucoma. Coming to other disorders, disc size asymmetry is one of the commonest reasons why a patient gets branded as a glaucoma suspect in spite of a normal perimetry and OCT. So when you see a patient with a normal intraocular pressure, normal OCT and normal perimetry, go back and look at the disc size, because this is something we don't always look at. We always look at the rim and sloping and focal defects, but disc size is something we tend to miss in a routine practice. Axial myopia itself is a risk factor for primary open-angle glaucoma. Perimetry is fraught with many artifacts because of the enlarged blind spots, and arcuate scotomas can be present even in tilted disc. OCT in these patients, again, it is quite difficult to get a good OCT image in these patients. And even when you get a good OCT image, as you can see in this patient, you can see there is a temporal shifting of the retinal nerve fiber layer peaks. Though you have the superior and inferior peaks there, they are a little shifted temporarily, because of which there is a red disease showing up in the OCT, whereas actually this patient has a normal perimetry, and clinically also the disc is normal with a normal intraocular pressure. So fundus photographs and visual fields are a good way of following up these patients very closely. Mimickers of angle closure glaucoma, anterior uveitis versus acute angle closure glaucoma, we often discuss, and we are clear about this. There is a characteristic history of colored halos, shallow AC, mid-dilated pupil, glaucom flecken, all point towards a diagnosis of acute angle closure. What is more tricky is when you have secondary angle closure due to uveitis, and you have to distinguish this from primary angle closure disease, especially when it presents bilaterally. Can I take a minute, Nina? Yeah. So if there is a history of photophobia, keretic precipitates and presence of cells and flare, posterior synechiae, presence of a meiotic rather than a mid-dilated pupil, it is worthwhile investigating these patients further by a B-scan or a UBM, where you may pick up peripheral choroidal detachments. And it is important to have a high index of suspicion for this, since the treatment protocol for these two conditions are very different. You do not want to end up doing a YAG PI in a patient who already has a uveitis. Congenital glaucoma is beyond the scope of this talk, but any of the symptomatology of congenital glaucoma can be confused with other disorders, because these patients are definitely not being able to cooperate for a complete examination. So don't go by a single parameter, do the complete set of investigations for congenital glaucoma in all these patients and follow them up over time. So to conclude, be cautious about diagnosing the presence or absence of glaucoma based on a single parameter, and consider the entire clinical picture from the vision to the pupil to the anterior chamber reaction to the fundus photos to fields to perimetry and OCT and UBM and B-scan as and when necessary. That's it. Thank you.
So next I invite Dr. Thomas Arun Verghese to speak on optic neuritis, mimickers and masqueraders.
Good afternoon. At the outset, I'd like to thank KSOS and Dr. Nina for this opportunity. So many cases we think, especially young female, we think it's optic neuritis. But sometimes a detailed examination will tell you that the cause is something quite different. I acknowledge my mentor in neuroophthalmology, Mr. Barr, and every case looked upon like a case of Sherlock Holmes. So these are different cases of optic disc edema, and only the one on the left, middle left, is optic neuritis. All the others were very different etiologies. And we'll go through these one by one. So history, examination, investigations are very useful. History you use your ears, examination, you use your eyes, and then you use what is between your ears to come to the diagnosis. Approach to disc edema, you can use, these are your tools, and as I said, additional symptoms give you a big clue. Differentiate true versus pseudo disc edema, unilateral versus bilateral. As you know, in optic neuritis, usually it's a unilateral presentation, so mainly cases of unilateral disc edema would become in your differentials. Don't forget blood pressure, general examination. I'm feeling the temporal artery here, any fullness of temporal fossa, and additional features. So true versus pseudo disc edema, that's the first thing you need to differentiate. So the two most useful C's, the color, cup, contour, circulation, and complete retina. The cup, as you know, in true edema it goes late, while it lost early. It is absent very often in pseudo disc edema. And circulation, the C's. The blood vessels are usually very clearly seen in pseudo disc edema. And as I said, typically optic neuritis, you're thinking of unilateral causes like posterior scleritis, uveitis, AION, neuroretinitis, and compressive lesions. And very unusually, bilateral cause, those causes which present usually bilaterally may start in one eye and then in the other eye. So I am a clinical person. I mainly look at additional features in the examination. For example, a pale optic disc indicates an AION, and additional features like a macular fan indicates a neuroretinitis. If there's associated choroiditis, you're thinking TB. If there's associated proptosis, it can be very mild, you're thinking an orbital mass. Extreme severe pain generally indicates an posterior scleritis, and I'll show you examples of these. So this is a lady I saw when working in the UK, 3 weeks, blurring of vision left eye. You can see the disc edema, and she also had the fullness of the temporal fossa, and that indicated a bony lesion, and that was very beautifully seen on the CT scan, which showed a fibrous dysplasia. So a general survey of the patient will give you important clues as to the possible cause. Again, 35-year-old who presents with blurring in the right eye, but you see the other features. You see the extensive cotton wool spots. That indicates a systemic cause, and it's actually due to hypertension. This is a very interesting patient, typical optic neuritis age group, 29-year-old with disc edema, and you can see she had a doubtful choroidal elevation infranasally. So I evaluated for tuberculosis, MAN2, and when she came back with the MAN2, she had developed a new lesion, which you can see here supratemporally, and there's a subretinal abscess. So that indicated possible tuberculosis, and we started ATT, and she had a very good outcome with the ATT. So although the typical optic neuritis age group, it was a very good decision not to whack her on IV methylprednisolone for 3 days. So uveitis, the important clue was the anterior vitreous cells and the small choroidal elevation. Again, a 40-year-old presented with blurring in the right eye. You can see the disc edema and some pallor, but you examine the other eye, it's almost like a chronic papilledema, almost like you have the typical champagne cork appearance. So this was actually an AION in a papilledema. So when in a chronic papilledema, they develop a compartment syndrome leading to AION and sudden worsening of vision, which can simulate an optic neuritis. A 65-year-old who presented with blurring in the left eye. Again, you can see this disc edema in the left eye, but the other eye examination showed pallor. So you had pallor optic atrophy on one side and disc edema on the other side. And this is a case of Foster-Kennedy syndrome. So even though the present symptoms is in the left eye, very important to always examine the opposite eye, which gives you important clues. Very interesting patient here, 39-year-old, presented with severe headache and pain and photophobia. Actually, I was not even able to examine the fundus at the first visit because of the marked photophobia. Gave topical steroids for a few days, came back in 3 days. I was just about able to examine the fundus and take this photograph, which showed a disc edema in the right eye, and her pain was sort of out of proportion to the congestion. So I was suspecting a posterior scleritis, which it turned out to be with the B scan, but the story did not end there. We gave obviously high-dose systemic steroids, and she responded. So disc edema with severe pain, you're thinking posterior scleritis. But the story, as I said, did not end there. She came in 2019 with some complaint in the left eye, and you can see an exudative retinal detachment. Again, we gave her systemic steroids, and that settled down. And at that point, examination of the right eye showed a sunset fundus. So this was actually a VKH presenting with posterior scleritis, but presenting first as a disc edema. And 4 years down the line, we got the diagnosis of VKH. And again, the exudative retinal detachment settled very well with systemic steroids. A 16-year-old 11th standard student presented with some pain, blurring, and she had features of panuveitis, anterior and posterior inflammation, and bilateral disc edema. So you're thinking sarcoidosis, TB, toxoplasmosis. ACE was very high, and she was started on systemic steroids, responded initially. She even developed a facial palsy. She phoned me one day and said, "My face looks a bit funny," and sent me this photograph. So she had developed a facial palsy. Again, we increased the systemic steroids. She even developed new vessels on the disc. We did a PRP, and finally, she is doing very well. So started off with the disc edema, but additional features. So always the additional clinical features gives you important clues. The uveitis features suspected sarcoidosis and TB, and gave a good result. Last patient here, 31-year-old. He had presented with some blurring. He's a professional driver. And actually, he actually didn't think anything wrong with his eyes. He got married during the COVID time, and his brother-in-law, who was watching the wedding online, said, "Your eyes look a bit funny. You better go and see an eye specialist." And he came. You can see there's disc edema on the right side and a mild proptosis. And so disc edema plus proptosis indicates an orbital lesion, and he had a cavernous hemangioma. And Dr. Marian operated him, and you can see he's done very well. So take-home message: detailed history, focused examination, differentiate true versus pseudo, unilateral versus bilateral, look for additional features. There will be some additional features which will help you differentiate from a typical optic neuritis. Systemic examination, blood pressure, don't forget, and investigations, blood and imaging where necessary will give you the diagnosis. Thank you.
Thank you, Dr. Thomas Arun. Dr. Thomas Arun Verghese is a very senior consultant working in Cochin at many hospitals with special interest in neuro-ophthalmology and glaucoma. So now let me call upon Dr. Divya Balakrishnan to speak on uveitic masquerade syndromes. Dr. Divya is a senior consultant in vitreoretina at Little Flower Hospital, Angamali.
Good afternoon, everyone. At the outset, I would like to thank Dr. Neena and KSOS for having me here. So my topic is uveitis masquerade syndromes. These are a group of various ocular diseases that mimic chronic intraocular inflammation. But actually, these are non-inflammatory cells like blood, malignant cells or pigments, which are secondary to some underlying non-inflammatory disease. So these can be either neoplastic or non-neoplastic. So some of the neoplastic conditions which may present like uveitis, the common ones being primary intraocular lymphoma, leukemia, uveal melanoma, retinoblastoma, metastatic lesions, and paraneoplastic syndromes. So while making a diagnosis, ocular pathology is found to be one of the most important things which helps in diagnosing these neoplastic masquerade syndrome. Now coming to non-neoplastic uveitis syndrome, the common ones being like retinal detachment, sometimes missed intraocular foreign bodies, persistent cortical matter. It could be drug-induced or like underlying retinal vascular diseases. And multimodal imaging is the one which gives us a clue to detect the underlying pathology. And whenever there is an involvement of the optic disc or a retinal vessel, that gives a clue that the patient might be having a systemic disease. I'll give you examples of neoplastic uveitis syndromes. So this was an elderly patient who presented with a sudden decrease in vision, and the patient on presentation had this a picture. Actually, the right eye had as a hemorrhagic or a blood-stained hypopaeon, and the left eye had hypopaeon. Because of this dramatic presentation with no history of trauma, a suspicion of something beyond what we are seeing was there. So the patient underwent an AC tap, and the sample was sent for both the micro and pathology. And this what the sample showed, that there was myeloblast. So the blood-stained hypopaeon and the mild heterochromia was the one which made us think something beyond. This was another case where a 14-year-old boy presented with a decrease in vision and headache. On examination, anterior segment was normal, but fundus showed multiple pockets of neurosensory detachment or subretinal fluid was there. So seeing the first, we thought it could be a VKH, and the patient was sent for OCT and fundus fluorescein angiogram. OCT showed neurosensory detachment with few hyperreflective dots beneath, and fundus fluorescein angiogram actually did not show any hot disc except for some few hyperfluorescence in the late phases. So seeing this, we thought it doesn't look like a typical VKH, investigated the child, and the peripheral smear examination showed there was 75% of blast cells, and further investigations revealed an underlying diagnosis of a B-cell acute lymphoblastic leukemia. So leukemia can present like neurosensory detachment, what we saw in the other case. It may present like hypopaeon. And when you see an already known case of leukemia patient present with this hypopaeon, think of a blast crisis or a CNS involvement. In children, when they present with this loose white hypopaeon with a white eye especially, think there is something beyond, and it may be a manifestation of retinoblastoma. Retinoblastoma can even present like an endophthalmitis also. So this was a 2-year-old kid with a history of fall, had sustained lid tear, had got operated for the lid tear and conjunctival tear, and was referred as a case of traumatic endophthalmitis. So when the kid was in, I don't have the slit lamp photograph or the anterior photo, but it was looking similar to the first case with that hemorrhagic hypopaeon. So B-scan was done. B-scan showed anyway vitreous echoes was there. There was increase in the RC thickening. So a diagnosis of traumatic endophthalmitis was made. Patient child was posted for vitrectomy. While doing vitrectomy, the surgeon found that something was abnormal in the vitreous. It was not looking like a typical endoff. Sample was sent for pathology and microbiology. It turned out to be a case of retinoblastoma. So trauma history in children, always be careful. Re-evaluate the imaging, especially B-scan, and take a proper history. There might be something beyond what we are seeing. This is another case where the patient was treated as a case of ocular tuberculosis, presented with the hypopaeon uveitis. The fundus picture, it showed vitritis. There was yellowish subretinal lesions and infiltrating onto the disc. Actually, we can see the disc hemorrhages. A closer look at the lesions, you can see that there is yellow, orange-yellow infiltrates, subretinal, and this looks like leopard spots. And the other eye, when we examined, had multiple sub-RPE lesions. The B-scan again showed heterogeneous diffuse lesions infiltrating onto the disc. The OCT, actually, you can see there is outer layer hyperreflectivity of the retina and nodular appearance of RPE and these hyperreflectivity of the RPE and the subretinal infiltrates. When you see this nodularity of the RPE, always keep in your mind a differential of lymphoma. So this turned out to be vitreoretinal lymphoma, and whenever you treat any patient with anterior or intermediate uveitis not responding to your treatment, then keep lymphoma in your differential diagnosis. And when you plan for a biopsy, always make sure that you wean off the patient of your steroids for at least 2 weeks before planning for biopsy. This was another case which was reported, again treated as idiopathic choroiditis. See, you can, because of that yellowish white lesion at the fovea, patient initially treated with steroids, showed mild response, but later presented with history of seizures. During that time, a neuroimaging and further bone marrow aspirate revealed that the patient was actually having primary CNS lymphoma. So these OCT feature actually with this RPE nodularity or a hyperreflectivity at the level of the RPE and subretinal, always keep your antenna up to see whether you are missing out on something. And this is a known case of CA breast patient presented with bilateral subretinal yellowish lesions. And because of this history, the patient was subjected to PET scan, and this turned out to be a metastasis widespread with liver, bone, and choroid mets. So these are few cases of neoplastic. Some non-neoplastic uveitis masculoids. This was a patient present with a sudden decrease in vision, bilateral vision PL. And you can see the anterior segment, there is congestion and significant choroidal edema, corneal edema with fibrinous membrane in both eyes precluding the fundus view. And so this case was actually referred elsewhere as cases of acute ankle closure glaucoma, was planned for YAG-PI. Because there was no fundus view, it showed like there was a peripheral choroidal detachment in both eyes. And when we took the history, actually the patient was recently started on topiramide. So with the history of the drug, the patient, with consultation with the neurophysician, the drug was stopped and the patient was started on topical and systemic steroids, and this is how it responded. And this is another case which reported the patient, a retropositive child on antiretroviral therapy, started on rifabutin, clarithromycin and ethambutol. And this kind of hypopia and uveitis, you can get it in these cases. This is a case which is a mentally challenged child who was treated as uveitis for 2 months with complicated cataract and posterior synechiae. When we saw, we did a B scan. The right eye was a closed funnel RD, and this is the anterior segment of the left eye. The B scan was showing again retinal detachment. So we operated this child. The child is mobile now. So whenever you see anterior uveitis, just make a point that you see the fundus. You might be missing a rhegmatogenous retinal detachment behind. So in these cases, actually, especially when you see a bloodstained hyperpayon or a hyperreflective RPE, have a high index of suspicion, especially when you are treating cases refractory to your uveitis, refractory to your treatment, or showed some initial response and then resistant to treatment. Always revisit the history, look at your investigations again if you are missing out anything. So multimodal imaging and with the neuroimaging, with the vitreous biopsy or ACTAP, subjecting to especially if you are not getting any diagnosis, please subject the sample to all these cytopathology, immunohistochemistry, flow cytometry, cytokine analysis, and now the molecular next generation sequencing. You might get something. So thank you. So don't miss on any life-threatening or vision-threatening conditions. Thank you.
So thank you, Divya, for that beautiful illustrative case series of masquerades and uveitis. So now we have next Dr. Lekha T. She's a senior consultant in retina at Giridhara Institute, Kochi, and she will be speaking to us on central serous retinopathy mimicus.
Thank you, Dr. Nina and Scientific Committee of KSOS. Central serous retinopathy, or CSR, is a very common condition that we see in our clinical practice. Usually seen in the age group of 20 to 50 years, they come with complaints of central scotoma or metamorphopsia. Fundus examination reveals pocket of fluid, and OCT confirms the fluid. Apart from that, might show a pigment epithelial detachment and features of pachychoroid. Depending on the chronicity, it can be acute or chronic. So this is a 46-year-old lady with blurred vision since 1 month. She had similar complaints earlier. Fundus examination showed SRF over the macula, and which was confirmed on OCT. You can also notice a small double layer sign. And fundus fluorescent angiography showed small 2 pinpoint leaks, which progressively increased in the subsequent phases, showing a typical ink blot and a smokestack leak, confirming our diagnosis of acute recurrent CSR. So as we have been already hearing in the previous talks, multimodal imaging is very useful to come to a proper diagnosis, for classification, for planning our treatment, as well as in the follow-up. We have a 45-year-old male here who's a known case of CSR in the past. He came with a recent decrease in vision, and you can see there was some amount of fluid with significant RPE changes, more in the right eye than in the left eye. OCT, it is more of a shallow detachment with more widespread RPE changes, which can be made out on FFA also. Along with that, there were leaks which were seen in both eyes. So these are the features when you see when the disease has become chronic, because the fluid has lasted for longer than 6 months. And these are some of the SD-OCT biomarkers which will help you to diagnose a case of CSR and differentiate it from other conditions. But why is it that we are so concerned about the fluid in the macula? Normally, the healthy retina is maintained in a dehydrated, transparent state so that it is compatible with light transmission. And this subretinal space is just a potential space. It actually does not exist. And this dryness is ensured by a homeostasis between the fluid entry and the fluid exit. When any pathology disrupts this, then only fluid will accumulate, enlarging the subretinal space. And this can occur due to various reasons that causes an increased inflow, such as anything to do with the vascular permeability of the retinal or the choroidal vessels, or abnormal vessels as neovascularization, or increase in the permeability of the blood retinal barriers. And similarly, anything which interferes with the outflow, that is either with the RPE pump or the molar cells, we can have an exudation in the macular area. So very often we see different diseases which may be diagnosed as CSR. We also see CSR which is referred with a different diagnosis. We'll see more example and learn how to differentiate it. So I'm showing 2 cases, both with fluid in the macula and both with yellow lesions. The one on the left side on OCT showed fluid, subretinal hyperreflective material, and a vacuole sign. FFA showed the classical ink blot type of leak. OCTA did not show any network suggestive of CSR with fibrin. On the right side, little more elderly patient, you can see subretinal hyperreflective material, PED. There was a small lazy network which shows increased hyperfluorescence both on FFA and ICGA, definite network on ECTA showing that this is an AMD with CNVM. And this differentiation is important because the first case responded to laser, whereas the second case required anti-VEGF therapy. Very often we see that CNVM can exist in both CSR and AMD. Whenever you are seeing an elderly patient, other features of AMD, definitely try to rule out features of CNVM before labeling it as CSR. And again, emphasizing on the point that multimodal imaging is very useful. One more case of subretinal fluid with an yellowish lesion in an elderly man who is on treatment for CSR. But on OCT, you can see apart from the fluid, there is a typical hyperreflective double layer sign, thumb-like PED, sub-RP hyperreflective material, and pachychoroid. Hotspot on ICGA, definite network on the OCTA, giving us a diagnosis of polypoidal choroidal vasculopathy, and he did well with anti-VEGF therapy. And these two conditions, being two ends of the same spectrum, they can coexist. And here it is a leakage from the neovascular complex that is the reason for the exudation. So our aim is to treat it either with anti-VEGF or PDT if available. We'll go on to the next set of cases. Here, a young man with sudden decrease in vision since one day. Anterior segment was quiet, but fundus showed multiple pockets of fluid, which can be very easily confused with CSR. OCT showed significant SRF as multiple pockets, along with subretinal septa, fibrin, bacillary layer detachment. There were few hyperreflective echoes in the vitreous as well. And FFA showed multiple leaks, which you can see are more leaky and more numerous than what you see would in a CSR's case, giving a typical starry sky appearance. ICGA also showed hypofluorescent dark dots, giving us a diagnosis of weak age disease. And this is the most common inflammatory condition mimicking CSR, and it is very important because here steroid is the mainstay of treatment, whereas steroids are absolutely contraindicated in CSR. And here it is the inflammation that is leading to the leakage of fluid. That is why steroids help, and this patient did well with treatment. We have a 35-year-old lady with complaints of pain. I am insisting on the point: pain, redness and swelling with a counting finger vision, anterior uveitis, disc edema, choroidal folds, subretinal fluid, demonstrated very well on OCT. You can see the RP undulations, RNFL edema. With all this, we suspected posterior scleritis, which was confirmed by the T sign on ultrasonography. And this was further supported by the FFA showing the disc leak as well as a pinpoint hyperfluorescence. Here again, it is a scleral inflammation and the associated vasculitis, which is the reason for the exudation in the macula, and definitely steroid is a treatment. And this patient also did well with good resolution of the macular edema as well as a disc edema. This is a 55-year-old lady with defective vision for many years with a vision of 612 and 615. You can see apart from a little fluid in the macular area, there was yellowish lesion bilateral, which was hyper-autofluorescent, and the OCT showed this fluid, which can be confused with the CSR. But if you look at the line scan through the lesion, you can see hyperreflective material, making us suspect of a Best vitelliform dystrophy. ERG was normal, but EOG showed a reduced Arden's ratio, confirming the diagnosis. And here it is an ionic imbalance in the RPU milieu that leads to the accumulation of the fluid and the vitelliform material. And this patient is remaining stable for years. So this is a situation where you just need to observe and you don't need to make another diagnosis and do any treatment. We have a 19-year-old boy who is on treatment for CSR, counting finger 3-meter vision, and you can see significant fluid in the macular area, but the line scan through the disc gave us a diagnosis of optic disc pit maculopathy, which is due to a congenital abnormality, and here again the treatment is observation most of the time. One clue is if you see SRF with intraretinal fluid, then that is one feature of optic disc maculopathy, because here the fluid actually enters within the retina, then an outer retinal hole develops, and then the fluid comes into the subretinal space. Another anatomical variation that you can see is the dome-shaped maculopathy, which can present with features of chronic CSR, but a vertical scan through the macula will cleanse the diagnosis. Here is a patient who is on treatment for carcinoma lung, presented with a yellowish lesion with significant SRF, lumpy bumpy appearance on the choroid. giving us a diagnosis of metastasis. Here it was relatively easy because the patient was already on treatment for malignancy. We don't have to do any interference because systemic therapy itself gave complete resolution of the fluid. And remember, this is the most common intraocular malignancy, so we might come across these situations. This is an yellowish lesion with again fluid in the macula. OCT showed several horizontal lamellae. I'm sorry, I'll just take one more minute. And ultrasound shows a hyperechoic lesion with shadowing, suggestive of pseudo-optic nerve, and here we are dealing with osteoma. This is again another patient with significant fluid in the macular area. Detailed evaluation showed an orangish lesion above the disc, which was intensely leaky on angiography, giving the diagnosis of hemangioma, and this patient did well with PDT. This is my last case. He's a 10-year-old boy, came with redness and pain, was diagnosed as anterior uveitis on topical steroids, 660 vision. When we examined, the uveitis was resolving. There was suspicion of very shallow fluid clinically as well as on the OCT, and FFA or ultrasound did not contribute much. We were not sure of the diagnosis. We considered the possibilities of unilateral VKH or posterior scleritis or even masquerade. We started on steroids. 4 days later, vision dropped further. Anterior uveitis was not significant, but there was a significant increase in the SRF, which you can make out very well on the OCT. We shifted our treatment to IVMP, still no response. Uveitic masquerade workup, everything was negative. By that time, the child had to go back to his own place, and he then later went on to another hospital. There they did an examination under anesthesia, and they diagnosed it as rheumatogenic RD, and the patient was operated. So not all serous macular detachments are CSR. It can be due to a range of conditions from vascular, inflammations, dystrophies, anatomic abnormalities, tumors, and even rheumatogenic RD. So you should suspect when you don't have any risk factor, non-resolving fluid, and not responding to treatment. And I would also stress on the detailed history, thorough evaluation, and multimodal imaging, because a correct diagnosis can only ensure a correct treatment. And it's very important that we are aware of these possibilities, because eyes will not see what the mind does not know. Thank you. Sorry for taking that extra minute.
Yeah, thank you, Dr. Lekha, for that wonderful, case series. And she's clearly explained to us when to suspect a CSR mimicker and what are the clear signs of CSR on OCT. Thank you very much. So, Dr. Marian is going to take a few minutes before she comes with her presentation. So, if you have any doubts, you can take questions. We discussed mimickers and masquerades in glaucoma, amblyopia, optic neuritis, CSR, and uveitis. So if you have any doubts, please feel free to ask questions. I have a question. What is this bacillary detachment? That's a new term.
It is a split in subretinal fluid. The fluid is between the neuroretina and the RPE, that we all know. When there is a split within the myoid zone in the photoreceptors, that is within the photoreceptor layer, pocket of fluid occurs. That is called as a bacillary detachment. And it is like you observe in CSR, in inflammatory conditions like VKH, like there are a lot of conditions which can cause bacillary detachment. You will see a layer above the RPE in the outer boundary. So it is within the photoreceptor layer.
That's very characteristic of...
any condition with an acute presentation, whether it is inflammation or CSR, all these you can get.
Any questions that you want to ask? Your comments on CSR mimickers.
I think one more thing, I don't know whether you mentioned, Best disease, yeah, it's not done.
Sir, I would like to know regarding neuro-ophthalmologic conditions, how often you use OCT to follow up these cases? We often do perimetry for their cases. How often is OCT useful?
Thank you. As you know, optic disc, I don't rely much on OCT, but RNFL definitely I use. RNFL and GCC, as you know, in glaucoma I use, but optic disc as such, I don't use it.
You use it for following up these cases also?
Some cases like say IIH, I would do an imaging so that over time we can show the patient that if there is any improvement or if it's worsening, mainly for those purposes, but not really for the diagnosis. To show, to probably explain to the patient, I would use it. Yeah.
Can I add something? Yeah, actually OCT has a very specific role in neurophthalmology also. So there are in cases when you are suspicious of a disc edema, but suppose it's very subtle, and you can do an OCT, and if there is some RNFL edema, which is again it adds to your diagnosis, but it should not be the only thing which makes the diagnosis. For example, optic neuritis is a clinical diagnosis. Patient can have retrobulbar neuritis or papillitis. So if there is an RAPD and a drop in vision, then definitely the diagnosis is optic neuritis. But doing an OCT is also important for prognosis. For example, if you do an OCT and the patient has poor vision and has come to you, and you see that the retinal nerve fiber layer and the ganglion cell layer are all normal, you can at least for that time say it's an acute onset event. And when the patient comes for follow-up, after you have started the patient on methylprednisolone and steroids, you can do a repeat OCT at the end of 4 to 6 weeks when you would have, the whole thing would have settled down and patient has recovered the vision. And what we find is that in cases with there is a demyelinating pathology, there is some amount of, in most cases of optic neuritis, there will be some amount of ganglion cell loss, even if the visual acuity has recovered. So that shows that there is some axonal damage which is happening, and it is like the patient going into a boxing ring and getting a punch, recovering, but there is some trauma which has happened and there is some axonal damage. Though the functional visual acuity has recovered, there are some structural changes. So, and they say that in MS, even the opposite eye has some subclinical, ganglion cell loss, and ganglion cell layer loss is more sensitive than a retinal nerve fiber layer loss. We also follow up patients of IIH with OCT nowadays, because IIH patients will have disc edema, and we will document it with OCT, and also doing a GCL at that time. If the GCL is normal, then and you start the patient on oral acetazolamide, and you follow up next visit. When the retinal nerve fiber layer edema reduces, the RNFL edema comes down. And if the GCL is maintained, you know that, of course, there is no definite damage to the optic nerve. But suppose you see that even after the maximum tolerated or acetazolamide dose, the retinal nerve fiber layer edema sometimes will appear to have reduced on OCT, but you may find the pallor setting in. So in that condition, you may be wondering whether is it due to the patient is really responding to the therapy, or is it the optic atrophy happening here? Because the disease is progressing and not responding. Then if you do a ganglion cell analysis there, and if you get a progressive loss of ganglion cell, then you know the disease is progressing despite your treatment, and you may need to either step up your dose of acetazolamide, or you may need to refer the patient for a repeat lumbar puncture and a surgical intervention. So these are some, some experiences which I have had.
You need to do it quite often, then probably a month once.
We do follow up patients with OCT, all patients of optic neuritis, even papilledema of IIH causes, we follow up. IIH, 1 month, and then every 3 months, at least 6 months we do, depending on the acuteness of the condition. So I think Dr. Marian is not being able to make it because she is held up in OPL. So we can take some questions if you have any. We still have 10 minutes, I think. I have a question to Neetu. Sometimes we have patients with, patients who come to us with suspicious looking disc, and they have systemic risk factors of hypertension, diabetes, and you have this real confusion. Is it a post-AION optic atrophy, or is it a subtle glaucoma which is producing? Sometimes I feel in those, anyway, these patients have vasculopathic risk factors. is it a good idea to put them on an anti-glaucoma, or do you want to wait and look for any definitive progression of the visual field changes before you start them on AGM?
So, once branded as glaucoma, once you start anti-glaucoma medications for someone, it takes a long time for anyone to stop that treatment. So, and in glaucoma, nothing happens overnight. We have time to decide on whether there is some actual documented progression. So, unless there is a definite evidence of glaucoma clinically, we do not start any of these patients on medications, unless, of course, intraocular pressure is very high. So we would document these baseline OCT, HFA and fundus photographs for these patients. And old IONs, typically if it's a disc at risk, it's a smaller disc, there is pallor more than cupping, we would definitely observe. But a larger disc with a larger cup, if the baseline investigations are normal, probably we can follow them up over 6 to 8 months to see if there is any documented change. But having said that, high myopes, family history of glaucoma, thinner corneas, when there are suspicious changes in the fields, patients who cannot come for regular follow-up. So I think it has to be a decision which you have to make after discussing with the patient. But patients who can come for regular follow-up, I wait till I'm sure that there is definite glaucoma before branding that diagnosis on them.
My next question is to Dr. Divya. So when we have patients with VKH-like picture, what are the investigations we should do other than the ocular investigations? Like you had this patient with leukemia, isn't it? So can you tell us, and for the audience, in case of a VKH or a VKH like with multiple serous detachments like picture, before you label it as VKH, what are the other investigations you should do?
Anyway, VKH patients are a group of patients who might require immunosuppressants with time. So definitely we should get a blood routine done. And this patient, child whom I presented actually, because the angiogram finding was not very typical of VKH. So I had seen cases of like hematological malignancies or dyscrasias presenting like neurosensory detachments and CSR like leaks also. So that is the reason why I asked, and I think doing a peripheral smear is not like a very expensive test, and it is like something which you might pick up. Even in some patients of diabetic retinopathy, when you see that sometimes you know like that hemorrhages are not very typical of diabetic retinopathy, very superficial, like how you see in like hypertensive, like splinter hemorrhages and all. So when you see something which is not really fitting into that, then get a peripheral smear done, because that will pick up many of these underlying hematological malignancies. And if still you have a suspicion, then consider doing a bone marrow.
And, you also had a patient with metastasis, right? Which presented as the CA breast patient. So are there any specific imaging features of metastasis?
Even clinically also, you know, like when you see these choroidal mass, if you see that like a clinical picture, when you see if the amount of exudative detachment which you see is more, like when you think in differentials of hemangioma, metastasis will have more subretinal fluid and exudative detachment. So that is one clinical clue which you can get. And hemangioma, usually you will see that in OCT also, the choriocapillaries many times will be just maintained. But in metastasis, you will see that the architecture of the choroid in the OCT will be distorted. And the RP will be hyper-reflective, and it will be more lumpy-bumpy in cases of metastasis.
Again, a question regarding to VKH. I don't know if you remember the case I showed you with present with uveitis and disc edema. She did not have any retinal lesions at that point. At that point, would OCT, no clinical retinal lesions, just the disc edema. And as I said, over 4 years later, it turned out to be a VKH. So at that point, without clinical retinal lesions, would anything show up on OCT?
In the OCT, that enhanced depth imaging, EDA OCT, you can look at the choroid thickness. So VKH, usually you will have a very thick choroid wherein you will not be able to get the posterior extent of the choroid. So that might be one clue which might be there. Usually because we don't usually do kind of, when we don't suspect VKH, but maybe in this case, if you had done an EDA OCT, then you can look for the choroidal thickness, because VKH patients usually will have thick choroid, and instead of repeating the angiogram to follow up these patients on treatment to see whether they are responding, OCT is another useful tool to follow up these patients also. So you will see that eventually the choroidal thickness will also come down.
I think OCT is a must nowadays, even for neuro-ophthalmologists, because many cases which were diagnosed as optic neuritis, sometimes we may miss the subtle serous detachments. The OCT sometimes picks up the multiple serous detachments, and retrospectively we have gone and looked into the retina and found that it was VKH and not optic neuritis. Anyway, it will respond to IVMP initially, and it will come back with recurrence. So it is a good idea to do OCT whenever, wherever possible, because you can miss lesions.
Just to add on it, as even the cases with mimickers which present like retinitis, whether it is a lymphoma, so in all these cases, wherever possible, get an OCT done, because in retinitis you will see that the inner retinal layers will be affected. When it comes to lymphoma, you will see that it is at the outer retina and the RP, sub-RP level, which will be affected. Sometimes in cases of syphilis, you will see that the lesion will be affected more in the outer retina and the RP. So actually it helps to differentiate, because earlier before OCT we used to label everything it as subretinal or like choroidal. Now you can clearly make out where is the level of the lesion, and that actually help us to come to a diagnosis. And always see, what I see is that when we ask for OCT, if the area of interest is somewhere else, everybody will be happy seeing the macular OCT. So that should not be the point. So whenever you ask for an OCT and when you look for it, don't